we begin now the medical event. The first session, can I please invite the chairpersons, Dr. Reju Joseph, sir is the senior consultant at KIMS Health in Trivandrum. Dr. N. Junior Sunderesh, sir is at the Government Kudalur Medical College and Hospital, Annamalai Nagar, Chidambaram. Dr. G.S. Prabhudas, sir is the Senior Consultant at Institute of Bariatric and Metabolic Surgery, Gleneagles Global Healthcare City, Perumgam, Chennai. Dr. Deepak Subramaniam, Senior Consultant and Clinical Lead of Department of General Surgery, Surgical Gastro, Laparoscopic and Bariatric Surgery at MGM Healthcare, Chennai. I'll also take the honor to invite the first speaker, Dr. Balachandran PK. Sir is the Senior Consultant, Minimal Access and Bariatric Robotic Surgeon, Apollo Hospital, Chennai.
To start off today's proceedings, over to Dr. Premkumar.
With the permission of the chair, thank you. At the outset, I'd like to thank my good friend Dr. Rajneesh Mishra for organizing this. It's nice to have this Walls conference to go ahead again. We have been having this program for over 8 years and I've attended each one, and it's a pleasure to be here again. I think over the course of the next 2 days, you will be going through a lot of recent advances in minimal access surgery. So the ideal way to start off this program would be to start off with the basics. So for everyone, you need to have a good background to start work. You should know where you stand and you should know your principles. So that's why it's very important for everyone to understand the ergonomics of laparoscopic surgery. Now, what is this word called ergonomics? Nobody used to talk about this during the era of open surgery, but during laparoscopic surgery, all of us talk a lot about ergonomics this, ergonomics that, and with robotics even more. The basic idea of ergonomics is that man should interact with machine to give you the optimal outcome. The idea of using the machine in the ideal way is so that you can perform the task with ease and have a good outcome. So this is basically the concept of ergonomics in surgery. So as a novice, when you are starting a laparoscopic career, this is how you'll feel. I'm not able to put my ports properly, I'm struggling, I'm clashing with the cameraman, etc. But as time goes on and your ergonomic concepts improve, this is how your laparoscopic career will proceed. So very quickly during this 15 minutes, I would like to discuss about port placement, OR setup, patient positioning, the team, and all the various aspects that you see there. Port placement, there is nothing like uniform port placement in laparoscopic surgery, and as we all know, it is the most important aspect because the port placement is the very first step that you do in any laparoscopic procedure, and if you place your ports wrong, the entire surgery is going to get messed up. Port placement is always target dependent. And you also have to take the patient consideration. Is he obese? Is he thin? Is the umbilicus very low? Is it very high? Is there a scar in the midline? You may want to put a various needle through the umbilicus, but there will be a scar there. You want to do complex procedures, you want to do a stoma, you want to do a hand-assisted laparoscopic surgery. So in all these things, the port placement will differ. So you got to keep a lot of things in mind. You know that we have a 0-degree scope, a 30-degree scope, and a 45-degree scope, and each of them has a different purpose. The concept is that the target organ should be in the center of the field of vision. If you want to look at the gallbladder, if you want to look at the callous triangle should be in the center of your field of vision. And to maintain that, the optic axis, that is the angle between the center of the scope and the target organ, should be 90 degrees. Only then will you have a perfect centering of your target organ in the center of the field of vision. Also, you should maintain a good distance between the target organ and the telescope, and that should be around 75 to 125 millimeters with a 90-degree angle to the center. We've got different angles. One is called as the azimuth angle. The azimuth angle is the angle between the optic axis to the working port, and that should be around 30 degrees. So we're all very comfortable sitting, looking down at your plate and eating with your right and left hand with a spoon and fork. So that's why I placed that there. Now the azimuth angle should be 30 degrees, and the manipulation angle is the angle between your right hand and the left hand, and that should be double of your azimuth angle, that is 60 degrees. And the elevation angle should be around 45 degrees. So that is the angle between your instrument and the abdominal wall. So if your elevation angle is very high, you can't operate like this, right? And if it's very low, you'll be scraping against the abdominal wall. So the ideal elevation angle should be 45 degrees. The instrument ratio, that is the amount of instrument should be inside the abdomen and outside the abdomen, should be 50-50%. If a lot of the instrument is inside and very little is outside, even a small movement will cause a big movement of the instrument inside, and if a lot of it is outside, you'll have to move a lot just to create a small movement inside. So your port placement should be such that such principles should be maintained. Now all of us talk about triangulation while placing the ports. So if you have a good azimuth angle, a good manipulation angle, a good elevation angle, then there will be a good triangulation of the port with the target organ in the center of the field of vision. So this is the French position for gallbladder surgery. Unfortunately not very ergonomic, but we have got used to doing gallbladder surgery this way. The American position is the ideal way to do laparoscopic cholecystectomy, wherein we stand between the legs, the camera port is there, and you are looking at the gallbladder in the center of the field of vision. Another important thing that we have to realize is that divide your abdomen into the various quadrants. Never place more than one primary port in one quadrant. By primary port, I mean your camera port, your right hand working port, and your left hand working port. Each of them should only be in one quadrant, because if you place more than one primary working port in one quadrant, you will have clashing of your instruments or knitting needle effect, and you will keep banging into each other. Now, if you can see this, there are definitely two different pictures here. In one picture, you see that the camera is in the center and the right and left hand ports are on either side of the camera. This is called as an on-axis surgery, and that is the ergonomic way to do laparoscopic surgery. In the second picture, you see the camera is in one side and the right and left hand working ports are on opposite side. Here you will tend to clash, and that is called as off-axis surgery, which is also done but not the ergonomic way to perform laparoscopy. So always maintain the best angle between the instruments and the scope. Okay, that is very, very important. Now going on to OR setup. So as we all know, laparoscopic equipment, you have more equipment when compared to open surgery, and there's a lot of non-functional spaces, even more so in robotic surgery. So you should be in a position to organize your laparoscopic surgery, your theatre, in such a way. Now, all of us, unfortunately, in today's era, you see the laparoscopic trolley, the monitor will be the highest, and we tend to look up and operate, but that is not the way to do it. The ideal ergonomic way is called as a gaze down view. As you do in open surgery, you gaze down and look at the operation, and if the monitor is down, you will have less strain and you will operate better. And how far should the monitor be away from your eye? The size of the screen into 4. That is the right distance that the monitor should be away from your eye. Also, there is something called as an inline positioning. By inline positioning, I mean the surgeon, the target organ, and the monitor should all be in the same line. I don't want to be looking at the gallbladder like that and operating like this, So it has to be inline positioning. The surgeon, target organ, monitor all in the same line. And also there is something called as a visual axis where you are looking, and a motor axis where you are operating. Visual axis and motor axis always also should be in the same line. The table height, that's Reju there in the left hand, I think he remembers that in our Dundee training lab, where the table should be below or at the level of your waist. Because the table is very high, your elbows tend to go up, and after a while your shoulders start shaking and you cannot operate properly. Now illumination, always keep the area behind the monitor very dark so that you'll have a good illumination of the screen and you can operate well. The position you see, the left below, where the legs are apart, the arms are tucked by the side, that is the ideal position for a laparoscopic procedure. You have to realize in laparoscopic surgery, gravity is your assistant. Okay, you don't have anybody to retract the viscera, etc. So let gravity be your assistant and keep the target organ at the highest point of the table. Okay? So all these I already repeated, so I don't need to go through that again. And also have a straight posture, don't try to bend your shoulders, etc., so that you will not have pain in the long run. Now these are some challenges that we face. Suppose you have a scarred abdomen like this, you need to know how I'm going to create entry into the abdominal cavity. You can use a Visiport, you can do Hassan's technique, you can use the Palmer's point, and if you have multiple quadrant, it is easy if you're operating only in one quadrant, but if you're operating in multiple quadrants, if you have 2 monitors on the ceiling, it is good. Or you'll need to move the monitor to the opposite side when you're operating in the other quadrant. Always be an ambidextrous surgeon. Use both your hands so that you become a good surgeon doing complex intracorporeal procedures. And it is very easy to do mirror imaging of regular techniques. When you try to do more complex things like endosuturing, etc., by intracorporeally, it becomes very difficult. The cameraman, sometimes you notice when you're doing a gallbladder, your head starts turning like that. That's because your cameraman has gone to sleep and he's turning the camera head like that. Always make sure the camera head is straight, and if you're using a 30-degree scope, only the light source cable should move. And also, if you've noticed, in laparoscopy, sometimes you tend to go beyond the target organ, but you still think you've not reached. That is because there is no depth perception in laparoscopy and there is no shadow. The lower picture is the actual picture, but the upper picture is what you see in laparoscopy because of lack of shadow, because the light and the camera come together in one plane. Also, in laparoscopy, there is no tactile feedback. You would like to feel the organ like that, but unfortunately you don't. What you see is, what you feel in laparoscopy is the one you feel below. But with practice, you tend to develop a tactile feedback. Just another 2 more minutes. The cameraman should know what the surgeon is looking at. Suppose I want to clip the cystic artery, he should not be showing me the fundus of the gallbladder. So that's very, very important. The cameraman is the eye of the surgeon, and he should concentrate on what the surgeon wants to see. And also magnification, particularly when you're doing endosuturing. When you want to suture, hold the needle, you go close. When you want to, take the bite, you take the C-loop, you got to come back. So perfect harmony should be there between the surgeon and the camera person. When you have a very obese person with a very thick abdominal wall, the fulcrum will play a big role. So you have to know how to place your ports accordingly. And there are a lot of technical issues today. You have artificial intelligence, you've got robotic. So always come for such training programs and keep yourself in tune and in touch with the latest concepts of laparoscopic surgery. And probably I'll just skip that because I'm out of time. So just to recap, setting up the theatre, take more time before the surgery, setting up of the patient, and you will find that your intraoperative time will reduce. Table and patient positioning plays a major role in the better performance. Port placement is the most important step, because if you don't place your ports properly, your entire procedure is not going to go on well. Maintain the best angle between the instruments and the scope. Always triangulate your ports. Make sure the visual and motor axis in the same direction. Try to become an ambidextrous surgeon. Occasionally take a bite with your left hand, etc., etc. So what one has to realize is minimal access surgery is not a specialty, it's just a different way of doing surgery. Understand ergonomics for the procedure, have a good team who knows what you would like to do. Practice makes perfect. Practice, practice, practice. The more you do a technique, the better you get at it. Try learning from others' mistakes. When you see your assistant or your chief doing something wrong, learn from him and say, no, I won't do this next time. It's better than learning from your own mistakes. Know when to troubleshoot. When some problem happens, you should know how to rectify that. Accept a learning curve. Don't come for a basic lab program today and post a lab fundoplication tomorrow. Start from the easy procedures and move on to the more difficult procedures. You will enjoy your laparoscopic career. And most important thing, enjoy what you do, because this is what you're going to do for the rest of your life. So I don't think I'll be able to complete the second part of the talk. So with the permission of the chair, may I go ahead or can I stop?
I think if there is some time left for a presenter, probably we can include that talk in that. I think we'll conclude this talk.
Conclude? Thank you so much. Thank you. And I'd just like to finish by saying that we are conducting a conference in Chennai, so I wish all of you could come. It's exclusively hernia. So if all of you can make it, we'll be very, very happy. Thank you so much for your kind listening.
Thank you, Dr. Prem. The whole idea of this particular conference and this particular meeting to be held is whatever was taught to you, whatever was preached to you, will be already in your head. When you hear it from an experienced surgeon like this, you will find so much of common language that is being heard by you over the last few weeks or over the last few years. And when the practicing surgeon after a few years also says the same thing, it means that's a golden rule in laparoscopy. So thank you, Prem, for telling everybody that it should be a pleasure when you are operating, not pressure in your operation theatre.
Thank you.
Thank you, sir.